Thank you, Mr. Chairman and colleagues. It's a pleasure to be part of this session today because I think that patients who need the biggest challenge are those with pancreatic cancer. And despite new technologies, despite new combination of chemotherapies, I think we need to do an effort to offer these patients something more than 35 months in the best option. What we already know that have an impact on survival in pancreatic cancer, of course, surgical resection, and I mean with this R0 surgical resection, R0 on the retroperitoneal margin as well, no node involvement, no neural infiltration. But we know at the same time that surgical resection itself is not enough alone. So we need to give these patients adjuvant chemotherapy, and this is already established. For patients who have a non-resectable disease at time of diagnosis, we can have an impact on their prognosis by giving them neoadjuvant chemotherapy because this can lead them to receive surgery, and this surgery will have an impact on their prognosis. We know that a poor nutritional status has a bad impact on the prognosis of this patient. And last but not least, we know that refer our patients to a high-volume center will guarantee for them not only a better surgical result, but even a better surgical outcome. So how can we fit the irreversible electroporation in this setting? Here's some suggestions. For resectable and borderline or non-resectable pancreatic cancer, we can try to ameliorate the R0 resection rate. And for advanced disease, meaning the metastatic disease, we can try to control the spreading of the disease by the immune response of the host. Just a brief slide for who of you do not have confidence with the irreversible electroporation. It's an ablative technique based on a non-thermal principle, but on an electric field through 2 to 6 probes placed around in the tumor. And these probes create an electric field between each other through pulses and bursts of pulses. These pulses generate a temperature never above 45–50 degrees, so they did not generate heating around the probes and in the tissue. And the biggest advantage compared to other thermal techniques is that the tissue around the lesion is not heated. So we have a guarantee to spare tissue with collagens like vessels, major vessels, or bile duct, or the main pancreatic duct from injury thermal related. Here, the mechanism of the action of this electric field on the cellular membrane, it increases permeability, therefore the cell goes to apoptosis and therefore cell death. We said we can increase the rate of surgical resection and R0 surgical resection, and this is an interesting paper where the author, Kwon, focalized the attention on what he calls margin accentuation. And it means treating the last part after surgical resection, after having resected the neck of the pancreatic gland. It wants to treat the last part of the retroperitoneal margin with the probe of irreversible electroporation, going from caudal to cranial, and this is how he positions the probes and the overlapping area that has been treated with 2 passages. And he does this retrospective analysis of 48 patients, almost all of them treated with the neoadjuvant chemotherapy. And the judgment whether to give IRE to these patients was based upon the judgment of the surgeon in operating theater that highlighted the risk of having a R1 resection rate. So these some results, they obtain a good margin status with R0 resection 57% in locally advanced disease and 67% of R0 in borderline resectable disease. But the patients received different kind of chemotherapies. We had in this group 15 patients who received IRE as a first-line treatment, together with surgical resection, and they describe a very high peritoneal recurrence, almost 50% of cases. Looking at overall survival, they found out 22 months overall survival with a PFS of 10 months. And we do not forget that we need to compare the survival rate with survival in locally advanced or borderline resectable, resected after downstaging after chemotherapy. This is the largest series ever reported from Martin and his group of 200 locally advanced pancreatic cancer treated with irreversible electroporation. It's a retrospective study as well. All the patients underwent a course of neoadjuvant chemotherapy. After restaging, 50 of them were resected and received IRE as a margin accentuation technique. 150 of them underwent IRE in situ without resection. All the resected patients receive a vascular resection as well, arterial resection 37 out of 50%. They had a mortality rate of 2%, all the non-resected patients, and they had a local and distant progression-free survival 12 and 16 months respectively. But if we look at overall survival, 24 months was the total overall survival of the group, but if we divide these patients in the resected one, their survival was 28 months, 0.3, and the ones who received IRE in situ had an overall survival of 23 months. And don't forget, we need to compare this overall survival with the correspective group of patients. So survival with locally advanced resected patients after downstaging in the first case, and survival in locally advanced cancer with no resection in the second case. So here is where we can find a really advantage. This is a retrospective study again of 75 patients treated with percutaneous irreversible electroporation, all treated after a course of neoadjuvant chemotherapy. They all had locally advanced pancreatic cancer. 3 of them, after the treatment, underwent to downstaging of disease and received a surgical resection R0. They did not have any mortality rate, and they have a 25% of morbidity, but mild degree. This is what we find if we look at overall survival, 27 months with a PFS of 15 months. And this was impressive if we think that we need to compare this data to survival in locally advanced cancer not resected. But in this group, they considered as well even the 3 patients who underwent to downstaging and surgical resection. You can see that in literature we have very different results in terms of overall survival after irreversible electroporation. So comparing these different casuistics is very difficult. We arrived to the first prospective study of ablation with IRE in a locally advanced pancreatic cancer, percutaneous approach, 25 patients, half of them received neoadjuvant chemotherapy. They did not have any mortality rate, but they had severe morbidity in 32% of these patients. And when looking at survival, it does not seem that we can gain a big benefit with this kind of morbidity rate. 17 months overall survival and 11 months survival from IRE. And the authors themselves, they point out the fact that maybe we can get some benefit in survival, but the percentage of morbidity rate is really high. We get to the Impala trial from the Dutch group, published in 2017. It's a prospective study, 132 patients at the beginning of the study, treated with systemic chemotherapy, FOLFIRINOX and gemcitabine in 20% of cases. After irradiation, the 44 patients with no progression of disease were surgically explored, not all cases, but only 36 of them. And you can see after exploration, 14 underwent to resection, 15 underwent to IRE because of a persistence of locally advanced disease, and 7 patients underwent to bypass or simple laparotomy. You see below the morbidity and mortality related to this treatment, to the patients that underwent surgery. And what is really impressive is that mortality rate of IRE was 13%. Resection had a 7% of mortality rate, and exploration alone had a 14% of mortality rate. And if we look at overall survival, we don't have any benefit looking at IRE. 17 months with a so high mortality rate is not acceptable. We talked about trying to control the spreading of disease through the immune response of the host, and what began in the experimental setting with the animals at the beginning was to precede what some other studies in humans are trying to highlight. In this particular study from the group of Martin again, the authors try to find a possible window of targeting with immunotherapy in patients that received IRE. And they found this window between day 3 and day 5 after the treatment. We need to remind that, like all other ablative technique, thermal or no thermal, the ablation with IRE is not only a debulking. The immune activation that happens is local and systemic, and it's a different activation from the inflammatory response. And this activation works through the reduction of the immunosuppression, the increasing of the antigen-presenting cell, and the increasing of the cytotoxic activity. But at this time, there is no evidence that this immune response has a positive impact on survival. We can make an hypothesis that IRE can enhance the response of the host to the immunotherapy. So what's next? At this time, we have 18 studies open and registered on clinicaltrials.gov, and they are all over the world, from US to Europe to Far East. If you look at these studies and their design, most of them are made with a single arm of study. The patient selection is very different, from stage 3 to stage 4 pancreatic cancer, and the main outcome is still focusing on safety, and we need that, as we have seen from the other results, overall survival and PFS, and the role of the immune response after IRE. There is only one randomized controlled trial, the CrossFire trials, which is still ongoing, 138 patients with locally advanced disease. It will last 3 years, and it will randomize patients either to FOLFIRINOX plus IRE or to FOLFIRINOX and stereotaxic ablative radiotherapy. They will look at overall survival, PFS, quality of life, the immune effect pre- and post-treatment, and the serum markers value. It will end by May 2019, so will end soon, and we will have results available. I think this can represent, at this moment, the study, the street that will lead to some more interesting result after ablative therapy in pancreatic cancer. And when we don't know where to go, probably systemic review meta-analysis will help us to find the right way to interpret this data. And this is the last one published in March 2019 from Tim Polick. And they examined 43 studies for a total of 498 patients, and they divide this group of patients by the type of approach, open of them, percutaneous almost half, and only 4 patients with the laparoscopic approach. They look at morbidity and mortality rate, always dividing them by type of approach. The morbidity is really higher in the 4 patients with the laparoscopy approach, and it's comparable between open and percutaneous. But mortality, which is in total 2.2%, if we look at the type of approach, goes all to the open group, 4.4% of cases. And this might be probably explained by the fact that these patients go to surgical exploration, and the attempt before deciding the disease is still locally advanced can be responsible of postoperative complications. If we look at survival, the results are very, very different as well. 7 to 18 months, 6 to 14 months, depending on the approach, 10 to 17 months, 27 months as well. And the authors, at the end, they conclude by saying that conclusive and definitive evidence to support the survival benefit of IRE does not currently exist. So we need to take that. In summary, patients with locally advanced disease have to receive systemic therapy first. In irreversible electroporation, morbidity and mortality rate are not negligible, so we need to ameliorate this part. Maybe the minimally-invasive, and I mean the percutaneous approach, will give better results in terms of morbidity and mortality rate, but we have the risk of understaged disease because we know that surgical exploration will show in a not negligible percentage of cases micrometastatic disease. And we know at the same time that radiology underestimate the real downstaging of a locally advanced pancreatic cancer undergone to chemotherapy. We can make the hypothesis of a possible benefit in survival, but we cannot state that at this time. And maybe this benefit, it will work through the immune stimulation. So, going back to the first question, can local therapy with IRE improve survival? We don't have enough evidence to state that, so we need to have more data about it. Thank you.